Hello, everyone. My name is Jonathan Sullivan, and I'm the Vice President of Product and Membership Design at the National Quality Forum. Welcome to this latest program on how NQF members are responding to the challenges around COVID-19. We're glad you could join us, and we hope it will be informative. This program is made possible by you, the members of National Quality Forum. Members are the driving force behind NQF's mission to advance measurable health improvements. Together, we do the work that enhances healthcare value, makes patient care safer, and results in better outcomes. Members continually demonstrate their shared commitment to the NQF mission through engagement and service, and our panelists today are no exception. We are grateful to Libby Hoy, founder and CEO of Patient and Family Centered Care Partners, and Dr. Mike Woodruff, the Senior Medical Director in the Office of Patient Experience at Intermountain Healthcare. Libby and Mike are the co-chairs of the National Quality Partners Action Team to co-design patient-centered health systems. Today, they will be sharing insights on how health systems can partner with patients, families, and caregivers in the unique and challenging circumstances posed by the COVID-19 epidemic. We will also be hearing from Meredith Gerland, a Director of Quality Innovation on the National Quality Forum staff. Some quick logistics as we get started. We hope you'll take an active role in the question and answer portion of the program. However, please help us stay on topic and refrain from questions or comments that aren't related to the information being shared today. We've muted all phone lines to ensure that unexpected noise doesn't interfere with the program. We'll be taking questions through the web interface and through the phone lines. If you're on the web, we are displaying instructions there now for how you can ask a question. If you're only on the phone and unable to see the instructions, I'll prompt the audience when it's time for phone questions. At that time, you can hit *7 on your phone to unmute your line. When you've asked your question, please mute your line again by hitting *6. Kicking off our program today is Meredith Gerland, the Director of Quality Innovation on the National Quality Forum staff, who has been working alongside fellow NQF staff member Chuck Amos to lead the National Quality Partners Action Team to co-design patient-centered health systems. As a certified professional in healthcare quality, Meredith focuses on bringing together stakeholders to collaborate and drive change on the nation's most pressing healthcare issues. Meredith has led NQF initiatives on wide-ranging topics in healthcare, including opioid stewardship, behavioral health, antibiotic stewardship, workplace safety, and patient engagement. Prior to joining NQF over 3 years ago, Meredith was a senior infection control epidemiologist at the Johns Hopkins Hospital, where she collaborated with individuals across the health system to prevent hospital-associated infections and improve patient care. With a background in public health, Meredith has also served as an international consultant to the Centers for Disease Control and Prevention, the World Health Organization, and the United Nations on numerous patient safety initiatives. Meredith earned her Master of Public Health and Epidemiology at the Boston University School of Public Health and her Bachelor of Arts in Psychology at Boston University. Meredith is going to give us an overview of co-design, and she'll be kicking things off today. Meredith?
Great. Thank you so much, Jonathan, and good afternoon, everyone. Thank you for joining us today for our webinar focused on patient, family, and caregiver engagement inside a pandemic. I'd like to first begin by thanking each of you who are key stakeholders in our nation's healthcare system for all of your incredible work in response to the COVID-19 pandemic. We know you are each working tirelessly to keep the public, your patients, your community, and your fellow healthcare workers across the nation safe. We all recognize that the healthcare community has grown and evolved with regard to patient engagement and shared decision-making. But engaging patients, families, and caregivers in clinical care decisions isn't enough. Patients, families, and caregivers are key stakeholders and users of healthcare, and thus they must be engaged in the efforts to design and improve these very systems. This sentiment was the impetus for NQF launching the Ntp Action Team to co-design patient-centered healthcare systems late last year. We heard from our NQF members as well as from the Ntp Leadership Consortium that a shift needs to occur in healthcare to begin understanding, prioritizing, and implementing co-design initiatives. The Ntp Action Team is a group of 29 diverse NQF member organizations who have been meeting since last December on a monthly basis. The Action Team includes representatives from nearly every sector of healthcare, and more than 1/4 of the Action Team is comprised of patient advocacy organizations. The goal of our Action Team is to identify actionable strategies and practices that organizations can use to create a culture that truly embraces co-design in quality and safety initiatives. For some on this call, co-design in itself may be a new term or concept. On the Action Team, when we think about co-design, we think about the act of collaborating with patients, families, and caregivers as equal partners in designing healthcare activities that affect quality of care and experience. As you can see, this goes well beyond engaging patients in their own clinical care decisions. Over the last several months, through the leadership of our Action Team co-chairs, Libby Hoy and Mike Woodruff, who you'll hear from momentarily, we've learned from a diverse set of NQF member organizations who are leading and implementing co-design initiatives on a daily basis. We've had a robust dialogue across our Action Team about challenges that limit co-design efforts, lessons learned on how to overcome some of those challenges and barriers, and success stories of organizations who are engaging patients, families, and caregivers in co-design initiatives in innovative and effective ways. However, over the last 7 weeks, the conversation around co-design has taken on a new meaning, both for our Action Team and for the broader healthcare community. Stakeholders across the healthcare system are faced with limited resources, competing priorities, and unprecedented volume. And in the midst of this, each one of us is acutely reminded that the boundaries of healthcare professionals and patients are artificial. Everyone on this call here today is a professional, a patient, a family member, and a caregiver. And while co-design during a pandemic seems harder than it did before the pandemic, these active partnerships between healthcare stakeholders and patients and families remain important. During this time, we have undoubtedly been challenged to think in new and innovative ways as we navigate uncharted waters. When making decisions that impact the delivery of care, the quality of care, and the care experience, we must not forget the valuable knowledge and perspective that patients and families bring to the table. We must build on and leverage existing co-design mechanisms to support bringing the patient and family perspective into the COVID-19 response. The patient voice must remain central to the conversations that healthcare organizations are having around limited resources, changing care models, and providing compassionate care. And today's webinar will focus on just that, highlighting opportunities to effectively partner and co-design systems during this very unique time. So without further ado, I'd like to turn it back over to Jonathan Sullivan to continue today's discussion. Thank you.
Thank you, Meredith. So up next in our program are the co-chairs of the National Quality Partners Action Team to co-design patient-centered health systems, Libby Hoy and Mike Woodruff. Libby Hoy is the founder and CEO of Patient and Family-Centered Care Partners. As the mother of 3 sons living with mitochondrial disease, Libby has over 25 years of experience navigating the healthcare system. Libby began volunteering as a parent mentor in 1995 and has been working to improve health systems and empower patients and families to be active partners in care ever since. Libby strives to build the infrastructure and capacity for healthcare organizations to engage all patients and families, from the bedside to the boardroom. In 2010, Libby co-founded PFCC Partners to create a community of patients, families, providers, and healthcare organizations committed to the shared learning of patient and family-centered care practice. PFCC Partners also supports the PFA network, inclusive of more than 600 patient family advisors working in healthcare settings across the country to partner for improvement in the quality, safety, experience, and design of healthcare. Libby is committed to partnership and has served as a patient family advisor to organizations such as CMS, NQF, Patient-Centered Outcomes Research Institute, Sutter Health System, and many others. Dr. Mike Woodruff is the Senior Medical Director in the Office of Patient Experience at Intermountain Healthcare in Utah and Southern Idaho, combining the functions of safety, quality, and experience of care and caring for an integrated system with 23 hospitals, 170 plus clinics, and over 38,000 employees. The team supports fulfilled and empowered caregivers, helping people live the healthiest lives possible by co-creating a human experience that is caring, safe, effective, affordable, and accessible for all. He is a practicing emergency medicine physician and trained at the Columbia University College of Physicians and Surgeons in New York, Beth Israel Deaconess Medical Center in Boston, and the University of Utah Medical Center in Salt Lake City. Welcome to both of you, and I will turn it over to you to get started.
Well, thank you, Jonathan. This is Mike. I really appreciate the opportunity. I did want to make one note for everybody. At Intermountain, we intentionally call all of our staff, all of our workers that help care for patients, we call them caregivers. So if I say that, please know that I am referring to not only caregivers at home, but also to our caregivers who are part of the team to take care of our patients and keep them healthy. Would you go to the next slide, please, Jonathan? What I do know about this time is that this is a time of tremendous collaboration and change. I don't think many of us have seen this level of teamwork and rapid change in our careers or in our lifetimes. So what I'm sharing and what I think what Libby will share with you as well is really not in the with the idea that this is the best practice per se, or that we are the experts in this, but rather that this is what we're learning and what we're observing, and these are some of the challenges and the really creative solutions that that as a nation and as a collective organization we're coming up with. I'm really excited to hear the discussion after we're done sharing this content. So this first one is really based on an observation by some of our caregivers that when they were all dressed up in their personal protective equipment, that they didn't feel like they were connecting with our patients as well as they could, because you can't see someone's mouth, you can't see all of their expression, and they really felt they needed a little extra way to connect with their patients. You can go to the next slide. So they came up with the brilliant idea of writing their name on the front of their face shields. These are face shields that we've produced at Intermountain. They put a photo of themselves and then something about themselves on this. And once this idea came out, it really took off like wildfire and now has spread across Intermountain in a really great show of how to balance the compassion with keeping ourselves safe and keeping our patients safe. I would add to this that in the same vein, we've rapidly stood up a compassionate support team that is a multidisciplinary team that consists of care management, our Office of Patient Experience, caregivers, as well as palliative care, communications, and some other functions within our hospitals and our health system, all with the idea of providing useful tools for communication to help our teams communicate with patients and families in this time of extreme disruption. The way that healthcare is being provided right now is really changing rapidly, and we need to be sensitive to how we communicate with families around that, so that when, for example, they come and they can't have visitors with them in the hospital, we have really caring and human ways to speak with them about that. And then secondly, to provide a support team that will support teams that are having difficult conversations and facing really difficult care situations in our hospitals. You can go to the next slide. I think another thing that happens sometimes to organizations in the heat of battle in a situation like this is as we transition to a more formal incident command structure, there's a tendency it's kind of natural habit to let things go, to maybe lose our focus as we focus on more tactical and operational things, to lose sight of what we're really committed to and the compassion and the humanity and the care that we're trying to provide. And one way that we have worked against that comes out of our experience of Care and Caring team led by Dr. Ann Pendo. And we've actually added to our daily incident command huddles reviewing patient comments about what's going well. And I think that's a tremendous way to keep us focused back on our core commitments to our patients and to supporting our physicians and our nurses and our teams that are caring for patients in this really challenging time. You can go to the next slide, and I'll hand it over to Libby.
Thank you so much, Mike, and thanks to everybody for taking an hour out of your very busy schedules to join us today. I'd like to start, before I share a little bit about the telehealth, with a moment of just gratitude. I am incredibly grateful, as I said, to all of you who have joined the call, certainly to our frontline healthcare staff, to our healthcare leaders who are making tough decisions, and our policymakers. But I'm also just really grateful to all of my peers and community members across the nation who are doing what's been asked and staying safe. We'll talk more about that in a moment as well. But truly, we are all in this together. So gratitude to all. So as Jonathan mentioned, PFCC Partners hosts the Patient Family Advisory Network, around 600 folks who are in active partnership with health systems, with quality improvement organizations, research teams, and this is a community of peer learning, really. And so we've had an opportunity to stay in very close contact with this community over the last 7 weeks through weekly coffee chats, through our virtual meetings and our work groups. We've been in close contact with our advisory board who leads the community to ensure that we're being as responsive as possible and providing a convening place for anyone who needs to feel connected in these trying times. So organically, the conversation around virtual visits emerged and how people were starting to experience those. And so we've been collecting information, again, through all of those methods and some focus groups as well to learn how people are experiencing this really fast immersion into the virtual world. And I think one of the primary things that I wanted to share with you all is that we're engaging in a learning journey together, and I think that's really okay. And I just want to give everyone permission not to be an expert on how we're going to move forward with telehealth. At this moment in time, it's about learning, being humble, and I had my first telehealth visit a couple weeks ago with my primary care, and we were telephonic only. We didn't have video, and so we were working through it to try to figure out if I had a sinus infection. And she said, "Well, does it hurt here?" And I said, "Well, I can't see you." And so we fumbled through that, and then a moment later I said, "Well, no, it hurts more over here." And she said, "Well, I can't see you." And we just kind of embraced the fact that, we are going to fumble a little bit, and that's okay. So just really engaging in that learning journey, but also engaging your patients and families in that. We're learning a lot with you that could be really helpful as we stand up these systems. So really important to be humble learners in this. Evidence even here. So you see on the left there a telehealth guide that the National ITP FAC produced, so Patient Family Advisors produced to support people, regular people, in engaging in telehealth. And we started with the term telehealth, and through our conversations and focus groups and coffee chats, we learned that's a really kind of off-putting terminology, telehealth. It feels very scientific, very inaccessible in a lot of ways. And so the vernacular, as it shifts into more virtual visits, which is also a more inclusive term, inclusive of whether you're doing telephonic visits or whether you're using FaceTime or whether you're using telehealth virtual platforms. There's everything going on out there, so a more inclusive term was even helpful to learn. We heard from patients and family caregivers that clarifying the details of the visit. So what program are you using? Are we just using a telephone, or are we using a virtual platform that's attached to the portal? Are we just using a FaceTime or a Zoom meeting? And sort of working through that, and then providing that an opportunity to practice. Lots of folks had expressed anxiety and concern about getting on a camera, being a little self-conscious, worried about their clinicians seeing their home, those kinds of things. And when they went through a practice run, they felt that was really alleviated, and they were able to have a very valuable interaction with their clinician. We learned that coordinating with community-based organizations. So one of the things we were concerned about was the rural health communities and those folks who may not have access to high-speed internet. And what we learned was from one of our advisors in a town of 800 in Iowa, shared with us that they are laying cable all over the place in the Midwest, is what he said. And it's all in support of getting the students, the kids, into the school system and keeping them on track with learning. But what an opportunity for the health system to tap into those resources that are being put out in the Midwest. And so really kind of looking around and seeing what other systems outside the health system are doing and how we can collaborate. And then promoting the convenience of the virtual visits. Once we sort of had some conversation about the concerns and anxieties, we very naturally went into conversations about how convenient it is. We had one advisor who drives her child with significant disabilities and special needs across states to see a specialist. And she shared that she couldn't believe the convenience of not having to put her in the car, not having to raise her anxiety, and that she felt it produced a better check-in with that specialist because her child was in her own home and in her own comfort zone. So still a lot to learn, but some tips that we wanted to pass along. And with that, I think I will pass it back to Mike to share some of the ways Intermountain is engaging the community to stay at home.
Yeah, Libby, thank you. You can go to the next slide, Jonathan. What excites me about this and what I think is a bit of a silver lining here is that we have had the occasion to move forward with a lot of advancements in the way that we deliver care and the way we reach out and connect with our patients and our communities. And these are ways that will endure beyond the COVID-19 pandemic. I'm just going to flip through these slides real quickly and just show you that on our web page, that is the public web page for Intermountain, we're showing ways to interact with us through our symptom checkers and through a chat bot that actually you can interact with. And these have been ideas in the past, but now coronavirus has given us the opportunity to use these to keep people safe, keep people at home, and provide the right level of care for them. You can go to the next slide. This is just another one of our websites showing education about COVID-19 and about video visits and how to organize those. You can go to the next slide. And here's an example of, again, the chat bot that we've enacted or deployed so that we can communicate with our patients and our community members without having them have to come in or wait on a phone line. You can go to the next slide. We early on we've produced a number of videos, but this is one video that really engaged our community to stay home and stay safe, to be bold, be a hero, and stay home. And it's really our nurses and our other caregivers who are talking about their jobs, as you'll note, being appropriately socially distanced, and talking about how the community can really lend a hand in the effort of fighting COVID-19 by staying home when possible. Now, that's a message that we have had to be very careful to say, don't stay home if you're having dangerous symptoms, or don't stay home if you need care. If you need to have care, or if you need to have testing and you need to see your doctor or your caregiver, then you need to doing that, because we across the country have seen people staying home when they're having symptoms that could be a heart attack or could be a stroke, and that is certainly not the intended outcome here. You can go to the next slide. I'll just show you briefly a really cool project called Project Protect that's a partnership with between Intermountain and the University of Utah and the Church of Latter-day Saints to get 10,000 volunteers a week, and we've filled these weeks up to get them kits to build and sew medical grade masks. And the goal is to produce 5 million masks. As part of this effort, we've already produced about 50,000 reusable face shields that I showed you before that can be used in our hospitals and our clinics, and we've also partnered with other organizations to provide them. They're also producing reusable isolation gowns. So really giving the community a way to join the fight, and also at the same time kind of reinforcing that message that this is something that you can do at home while you're staying safe and doing your part to flatten the curve of the spread of coronavirus. You can go to the next slide, and I'll hand it back to Libby.
Thanks, Mike. I just think it's incredible, the opportunity to involve and engage your community in that way. We're doing a similar thing. PFCC Partners is organizing the Care for the Caregivers. This is a program we shamelessly stole from some colleagues in Denver with two goals in mind: one, to keep our local restaurants in business, and the second, to feed our frontline healthcare workers. So organizing donations, financial donations to keep those two goals headed forward. And those are really, I think, the opportunities to engage our community members in the health system in ways that we just haven't done before. And, you know, perhaps that is, as you said, the silver lining of the pandemic. I also just wanted to make the comment on, in terms of how how people are staying home, how are they receiving that message. I think two important points. One is that there's a consistency of message and clarity. There's no ambiguity about it. Staying home is staying home. And I think that that clarity across, basically every citizen of the U.S. at this point is really a clear and almost a collaborative message for everyone. We're just not hearing, at least here in LA County, we're not hearing messages of, threats, or there's no shame, there's no mention of enforcement. It's just really a genuine interdependence communicated through that singular message: stay home, stay safe. And in that way, we've created a social movement or a culture shift in a matter of weeks under one single unifying threat. So I think that's a really important thing to keep in mind as we move forward. And you can go to the next slide. However, we at PFCC Partners and within the PFA network have been a little bit concerned that we're hearing from health systems that have sort of sidelined their patient family advisory programs. And kind of, really well understood, as Mike referenced earlier, the incident command centers and the sort of chain of command operation that had to be stood up very quickly. There's less of a parent role for patient family advisors in that. However, we think that as time goes on, we think it's really imperative to continue those relationships, and maybe they're in newer and different ways, but we really want to be thoughtful about how we continue to have patient-family advisors who are co-designing with us. And so under the leadership of Dr. Sue Anderson and Bev Kreider, along with PFA Network, they have developed this paper on how to leverage patient-family advisory programs in this time. And again, I think that perspective, patients and families in your local communities, in your health systems, have on your systems, on your policies, it's a really critical voice to have present. Next slide, please. So I wanted to share a few of the ways that we've been hearing that health systems are engaging their patient-family advisors into the response. We've got Bellin Health System in Wisconsin, inviting their advisors to their daily town hall, their internal huddles, so that those advisors can then become sort of conduits to the community and take forward the messages of the planning and the effort and what's most up-to-date information. In Los Angeles County here, we are convening focus groups of patient-family advisors. We're surveying them to find out what is your biggest concerns, what are your biggest worries about this. Sometimes that had to do directly with health, but sometimes it had to do more with how do I get my groceries, or how do I access online pharmacy. So learning what was at top of mind for LA County residents meant we could feed that information back to the leadership at LA County Department of Health Services, and they could respond really genuinely and quickly to the concerns that were expressed. Rainbow Children's Hospital established a compassionate care team, similar, I think, to what Mike expressed, really to be there to support providing human messaging to what sometimes feels like inhumane visiting policies. And I think it's a really strong resource that can be tapped for that. We also heard from Sutter Health System advisors that they taped a gratitude video and sent it to all of the frontline healthcare workers across the vast Sutter Health System. So I just encourage everyone to think really strongly of their existing patient-family advisory programs and think about how to leverage those wonderful voices and collaborative partners to inform the responses to the COVID-19 pandemic. And with that, I will pass it back to Mike to share a really concrete example of how to get this hardwired into your health system. Mike, next slide.
Thanks, Libby. Thank you. I'm going to just show this template that we're using for planning for the kind of disaster response that's required by a pandemic. And I want to bring your attention, so the broad framework of this is that this is a tool that our teams are using to plan how care would be delivered differently when resources such as staff, supply, and space are limited by a large influx of patients. Now in Utah, we're very lucky that we're low on the curve right now, and so we haven't reached that crisis state, but certainly we've seen it happen in other countries, and we've certainly seen it across in different spots in the nation. And so this is really a proactive planning tool that we've used, and I want to call your attention to the fact that we've included a patient and family advisor in the framework on the decision on the deciding team, and that's really to try and hardwire the concept of co-design and how important it is that our patients are partners with us in looking at how different care might feel to them, what their experience of a different way of interacting with the healthcare system might be. And so we're early on in this work, and this is the latest version of this. Earlier versions did not have that, but this is, I think, a step forward in hardwiring this kind of care. I also wanted to share with you that on one of our planning teams that really looks at a similar topic of how we can make decisions around limited resources, we included 2 patient advisors from the very get-go one of whom is over the age of 65, and another of whom is younger but is a survivor of acute respiratory distress syndrome and was on a ventilator for a period of time in the ICU. And so really bringing that perspective of our patients in our community into the decision-making process early on for us has just been really a wonderful experience. And as a leader engaged on that team, it's a very, very valuable perspective to have on the team, to have a reality check of our thought processes. And I know I don't have to convince this audience of that, but I'll just tell you, it has been really wonderful. You can go to the next slide. I wanted to just end with a shout out to our colleagues at Northwell Health in New York City and New York in general. In Utah, we're very fortunate right now in regards to the pandemic, and we are nowhere nearly as impacted as our colleagues in our compatriots in New York City are. We've sent a couple teams out to provide some relief to the healthcare workers there, and we have learned so much from that experience. So my heart goes out to them and my thanks goes out to them. And again, I want to emphasize that this is a time of collaboration and rapid change where we can make improvements in the way that we think about healthcare, in the way we view patients being involved in the design of healthcare, and the way that we actually deliver care that will last potentially for decades to come. So with that, I will end my remarks, and Libby, thank you, and thank you to all of you. I am very eager to hear feedback and thoughts around these questions and others.
Well, we've had some questions start to get put into the chat box while you guys have been sharing your insights with us. Some of these address some things that you may have covered, but I'm going to give these folks a chance to speak up with their questions anyway, just to make sure that we've addressed them. Our first question is from Christina Mahdi, and she asks, how does Intermountain collect patient feedback, and do you do so virtually?
So we do have some virtual mechanisms for capturing the patient feedback. We use Press Ganey as our vendor, and we are very fortunate to have very rapid cycle feedback. I don't know if you noticed the dates on those patient comments were fairly contemporaneous in April. So we think that sharing the feedback and having that awareness is in real time is really important. Libby, did you have other thoughts on that?
No, I think you are fortunate to have that rapid turnaround, because I do think that helps to helps Intermountain to be able to be responsive.
I think we've got Ann Pendo on the line if she would like to comment. Jonathan, would that be possible?
Yes, by all means. You can hit *7 on your phone to unmute and chime in. You may have taken Ann by surprise, though.
Sure. Let's go to the next question.
We'll come back. So Lindsay Galley has a couple of questions. Lindsay, would you like to hit *7 on your phone to unmute your line and ask your questions? I think one of them might have been addressed by Libby's comments after you made it, but you had two questions in here. So Lindsay, do you want to ask your question?
Yeah, sure. Hi, this is Lindsay Galley. Thank you for the great presentation and the real concrete examples of how patients and families are informing this COVID response. One of my questions did get answered, but I was curious how healthcare organizations like Intermountain or others are connecting with or communicating with more vulnerable populations about COVID.
Yeah, I'll start with that one and then pass it to Libby. Thank you for that question. That's really important. We've seen the same in Utah that we're seeing across the country, that there are populations that are more vulnerable to the impacts of COVID-19. In our state, there's Native American populations and a sizable Hispanic population, and we're seeing those communities impacted. And so we are using all of our resources and all of our mechanisms of communication to communicate out to those communities in the appropriate languages and the appropriate culturally relevant ways about COVID-19, about the importance of social distancing, and about the importance of seeking care when it's necessary. We're also using, in partnership with the state, community health workers to get out and really interact with those populations to make sure they have the resources they need. Part of this is showing us the disparity in our healthcare system, and it's going to put a really bright light on that, and we're going to have to do work in the years to come to address those issues. Libby, any further thoughts on that?
Yeah, just to build on Mike's suggestions, in terms of reaching out to those vulnerable populations, one strategy, in addition to what Mike mentioned, is partnering with trusted community-based organizations. So here in LA County, we're really, really diverse, and we've got some great resources around that, but importantly, we have some very trusted organizations like family resource centers that the vulnerable communities that's a trusting source for them. So by collaborating with them, we're not only giving the messages in culturally acceptable ways, but from culturally trusted sources. And I think that's another layer. I think you're right, Mike. We're going to have to do a better job with equity in the future, and I think that's going to highlight the need and sustainment, the need for sustainment of our community-based organization infrastructure.
I'm going to take this opportunity to call on Ann Pendo. I did let her know, Mike, that you invited her to chime in, and she has indicated she would like to contribute a couple thoughts. Ann?
Yes, thank you. Can you hear me okay?
Yes.
Okay, excellent. Thanks, Mike, for asking me to comment, and I was frantically texting Mike some additional thoughts as he was answering the original question. And I wanted to share a couple thoughts with you. Mike and I work closely together in the Office of Patient Experience, and part of what COVID has challenged us to do is to think, who don't we have at the table that should be at the table? And creating those connections with our patients and then other parts of our organization, like chaplaincy and our employee assistance program folks and our community health experts, and recognizing how we put all of that together. I kind of liken it to putting the pieces of a puzzle together, and when they fit, what we're seeing is they fit really well together, which has been really lovely. And recognizing that our patients are only going to be as well as the caregivers at Intermountain. And so being very, very deliberate of looking at how does this work impact our patients, but also how does it impact our caregivers, and being really mindful and deliberate of making sure that it's a win for both of those groupings, and it's not one at the expense of the other. Mike, is there anything else you wanted me to address specifically?
And there's a question that just popped up that says, how do folks at Intermountain communicate the role and acceptance of patient-family advisors as the organization seeks to incorporate more of them into co-design strategies and outcomes? So I think you'd be perfectly suited to answer that question.
Yes, I would. Thank you, and I would love to answer that question. So our office has been, I think this is year 2, it might be year 3, and it's been an interesting journey, and sharing what we learn as we go out to groups has been one of the ways that we've been able to talk about the patient voice. We talk about it, but we don't act on it. And so sharing those learnings of we stood up this program, we thought it was so great, we were really excited, then we remembered, we should ask our patients, and the response and feedback that we got from them was completely different. So one of the ways is sharing those stories, like what did we learn when we included our patient's voice. So that's number one. The other piece, and Mike said this really so well in his role in our incident command structure, is he wanted to make sure that we had a patient participating. So it's our group being the modelers of the behavior we want to see. So, yep, we're going to do this, but let's get let's get some patients together and see what they think. And it's been, I go back to it being a deliberate action, and then asking questions to whatever audience is in front of us. What do our patients say about this? Because I think through no fault of our own, we sometimes forget about them. We get excited about what we're working on, and isn't this going to be great? And then we recognize, we didn't think about it in a way that mattered.
All right, thanks for sharing that. We are going to go next to Stephanie Bennett, who has a question about the chat bot, and this is actually one that's been on my mind as well, because as I've gone around and looked at how different systems are responding, chat bots seem to be a common feature, but I often wonder about their usability and how patients react to them. So Stephanie, do you want to hit *7 and ask your question?
Hello?
Hi, we can hear you.
Okay, perfect. Hi, yeah, I was kind of wondering about the chatbot feature. It seems as though it should be quite an innovative way to communicate with patients and families. But I am wondering about the types of responses you get and who's monitoring that. Do they find it user-friendly and actually useful? Thanks.
Yeah, so I'll tell you, I'm not the expert on the chat bot, but I will tell you some of the background. We have been doing work, and Anne's been involved in a lot of that work for quite some time on our digital front door, and how we can be more accessible to an increasingly kind of internet and electronic friendly community that we live in. And so there's been a ton of thought around the utility of chatbots, and there's been a patient and family advisor group deep in that work on a chatbot. So we built that into the chatbot. In terms of the deployment of the chatbot, we're going to learn rapidly, but we're very early in that work, and this will be a great way to get that experience. I'd be curious to hear from others on the call how they're using chatbots and what they've learned.
All right, we'll queue those up to address those shortly. Our next question is going to be from Kelly Goodson, and actually Kelly, I think, has a couple of questions. So Kelly, do you want to hit *7 on your phone to unmute your line and ask your question? Well, let me go ahead and ask it for her since we're not hearing her. So the first question is about how Intermountain has maintained relationships with its patient, family advisors, councils as this is going on. We talked a little bit earlier about how some of those groups may not be able to be convened as regularly. So how are you maintaining those relationships with those groups during this time?
I think one strategy, and then I will turn this one over to Libby. One strategy we've used is by reaching out virtually to them and asking, the work is still important and we still need their input. In fact, there's a sense in which we need their input more today than we did 6 weeks ago, even more urgently, I should say, because care is changing so rapidly and it's having such a big impact on our patients and our communities. So the more that dialogue can continue, everyone's meeting virtually now with family members, with friends, and with work. So there's no reason why the patient family advisor teams need to stand down or not be engaged. I see a related question about how we chose the specific patient family advisors to kind of interact with our incident command structure. We have long-standing relationships with our patient family advisors, and we also have a Center for Humanism and Medicine that's run by one of our great intensive care experts, Sam Brown. He's published widely on humanism and medicine, and he has relationship with specifically patient and family advisors that have experience being hospitalized in the ICU to try and understand what that's like and what post-ICU syndrome is like, and really get that patient view of that. So really that's how that came together for us. Libby, did you have other thoughts on how we can continue to engage the patient and family advisors?
Yeah, I think, thanks for the question, Kelly, and I'm sure you're seeing across Vizient what we're seeing across the country, and that is just wide variation of how health systems are using their advisors and tapping into. So a couple of quick thoughts. I think that, the strategy of engaging the patient family advisory role stays the same. It's a resource to, whatever program that we're standing up, and so it's important to bring them right into the work that you're doing. So if it's an incident command center committee, great, bring them right into that. If it's, another committee, a compassionate care committee that is influencing the messaging that goes out around visitation and the community messaging, great. Look at what your priorities are. Again, the strategy doesn't change. Look at the priorities of the organization and bring the patient family advisor voice into that. I think what I'm hearing in your second question around is maybe around the preparation. And so I think it's important that we, bring in advisors with experience, as Mike mentioned, with the health system, have a trusted relationship into that more sensitive kinds of areas. At the same time, you can be doing surveys and focus groups and things that the advisory council can lead for you that will get your broader voice. So it's not an all or one, it's an and, right? And I would say the same thing with the chat bots too. As we learn about how effective those are, that doesn't mean we drop off in any other method of communicating with our community. It just is an additional source. So I think really staying consistent to the idea that engaging the patient and family advisor in co-design is a strategy to improve outcomes. And when you think of it in that direction, then it becomes apparent where those voices need to be.
We're getting close to the top of the hour, but we do have a few more questions to be addressed. Our next one is going to be from John James. John, do you want to unmute your line by hitting *7 and ask your question? Let me go ahead and ask that question on his behalf. John expressed his concern that in a crisis situation, shared decision-making and informed consent may slip in importance. For example, he's read about hydroxychloroquine being given to patients apparently with little or no shared decision-making. In this kind of a situation, what advice would you have for our audience around how to keep up good shared decision-making practices?
So this is Libby. I'd be happy to take a first response at that. I'm worried about this too. I think it's really the fact that we're focusing on it is a good step in the right direction, but I think we need to do a little bit more. So again, looking at within your health system, where does shared decision making lie, and who does the training, who wrote the policy, where is that, and how can patients and families with lived experience in your health system be part of that conversation, and how we move shared decision making forward in these critical times. This is, really important that patients and families have all the information to make the best decision for themselves. And so I'm glad that you raised that concern. I think we need to keep that in the conversation as we develop these responses.
Okay, our next question is going to be from Mary Schranke.
Jonathan, could I just add to that real quick?
Sure, absolutely.
I think it's really our responsibility to build that into how we respond to a situation like this. And for example, in our compassionate support team, that's one of the items on the table is scripting around shared decision making. And we have been fortunate to partner with the state of Utah as well on updating the guidelines around pandemic crisis response, and we've been successful in advocating to include shared decision making in those documents as well. And so I think just wherever we can, wherever we're changing care or designing care, we need to build that shared decision making in, and we need to secondly facilitate communication in this really difficult time. One of the things that coronavirus in COVID-19 impacts is our ability to communicate with each other, with families, with patients, and with loved ones. So really working on those two things. Thanks. I'll turn it back to you, Jonathan.
Okay, well, unfortunately, we are at the top of the hour, and I want to respect the speaker's time and availability. So we are going to wrap here. In conclusion, I just want to thank you, Libby and Mike, once again for taking the time to share your insights with us and answer questions. And I'd also like to thank Meredith for giving us that overview of the co-design action team. So thank you all. We hope the information that was shared will be informative for you as you look to provide patient-centered care in your organizations. We know that many of you are on the front lines of the response to COVID-19, and we're grateful for your leadership and action. Please be on the lookout for a brief survey about today's program. If you could just take 60 seconds to give us your feedback, we would appreciate it. And I encourage everyone to tap into our amazing community of healthcare quality leaders. We have an active conversation underway on our online community, Member Connect, and the recording of this program, along with the slides, will be posted there shortly. This concludes our program, and on behalf of everyone at NQF, we wish you and your families continued good health amidst the COVID-19 pandemic. Have a good day.